On behalf of the APA Council on C-L Psychiatry Work Group on the treatment of opioid use disorder in the General Hospital, welcome to today's workshop. So I'm Margot Funk. I'm the Vice Chair of Education and the Residency Program Director for the Department of Psychiatry at Brigham and Women's Hospital, as well as the Director of Cardiovascular Psychiatry there. I'm joined today by colleagues Dr. Allison Smith, who is Assistant Professor in the Department of Psychiatry at the Medical University of South Carolina, as well as Joji Suzuki, who's Assistant Professor at Harvard Medical School, as well as the Director of Division of Addiction Psychiatry at Brigham and Women's Hospital. Also Stefania Buonacore, who is a PGY4 resident at the Harvard South Shore Psychiatry Residency Training Program, and Sean Jin, who is a PGY3 resident also at the Harvard South Shore Psychiatry Residency Training Program. I have one disclosure that I perform teaching for Acadia Pharmaceuticals, the content of which is unrelated to our talk today. So to set the frame for our workshop today, let's first touch on some of the key pieces of epidemiology about the opioid epidemic. So we know that the morbidity, mortality, and cost of opioid use disorder have dramatically increased over the past 2 decades, necessitating really a call to action for all of our healthcare systems and our healthcare providers, really regardless of specialty, to reassess the approach to how we're treating opioid use disorder. So looking at some of the numbers here, according to the Centers for Disease Control and Prevention, the CDC, during the period of time from 1999 to 2018, opioids, including both illicit and prescription, were involved in nearly 500,000 deaths in the United States, with a little over 67,000 deaths in 2018 alone. Now, the rise in opioid overdose deaths can be outlined really in 3 distinct waves. So the first wave began with increased prescribing of opioids in the 1990s, with overdose deaths really involving commonly prescribed opioids, and that's been increasing since 1999. The second wave began in 2010 with a rapid increase in overdose deaths involving heroin. And then in 2013, we start to see this third wave where there's significant increases in overdose deaths involving synthetic opioids, and particularly those that are involving illicitly manufactured fentanyl. In 2019, among people 12 years and older in the US, about 0.6% or 1.6 million people had an opioid use disorder. And of those, only 18% received medication treatment for that disorder. In the same year, among adults 18 and over with any mental illness, about 9% used opioids. And among those with serious mental illness, about 14% used opioids. So we know that people are out there with pretty significant comorbid mental illness and opioid use disorder. And so this is very relevant for us to know about and be comfortable treating. So patients with opioid use disorder may first engage in treatment through a variety of entry points into the healthcare system. These can include the emergency department, the general hospital, inpatient psychiatry, outpatient clinics, harm reduction services like syringe exchange services, supervised injection sites, or through the criminal justice system. The inpatient general hospital is an especially important point of focus given the significant medical comorbidity of opioid use disorder and the financial impact that it has on the healthcare system. So in 2018, among US adults 18 years and older, there were nearly 750,000 opioid-related inpatient stays, and this did not even include concurrent stimulant use. This accounted for 296 hospital stays per 100,000 people in the population. And this was an increase of 30.8% from 2012, which was quite significant. So it's really essential that we actively engage patients with OUD in the general hospital setting, where there may be more time and resources to develop and initiate a treatment plan in collaboration with the other specialty services that are treating all of the medical comorbidities of the opioid use disorder. And so the role of the psychiatrist really as the expert in the treatment of substance use disorders, comorbid psychiatric illness, and harm reduction strategies, we can really be a great benefit to the hospital team. Now, unfortunately, and I think for many reasons, the psychiatrist is often not a member of this treatment team. And the absence of psychiatry here may be due to a number of reasons, including the prevailing hospital culture, perhaps lack of local psychiatry consultation liaison services, maybe the presence of other specialty services who have kind of owned this role, such as addiction medicine, or psychiatrists' lack of comfort and education treating patients with OUD, and finally, lack of knowledge about the scope of psychiatry, perhaps by other consulting members of the treatment team. The other thing, we must question is what about our own in psychiatry poorly acknowledged stigma against patients with OUD, and how much does that play into this gap? So to address many of these gaps, the APA Council on Consultation-Liaison Psychiatry, in collaboration with the APA Council on Addiction Psychiatry, convened an expert work group with representation from the ACLP, the American Academy of Addiction Psychiatry, the Association of Medicine and Psychiatry, to prepare really a unified resource about the treatment of OUD for psychiatrists practicing in the general hospital setting. And to best inform our process, our work group convened a roundtable discussion back in December 2020 that officially identified representatives from different specialty organizations who have high stakes in the best practice in hospital treatment of patients with OUD. And the roundtable discussion included the American Society of Addiction Medicine, the Infectious Diseases Society of America, American College of Obstetrics and Gynecology, American College of Surgeons, and the American College of Emergency Physicians, as well as the American Hospital Association. So representatives from all of these stakeholder organizations were officially invited by the APA and asked to discuss specialty-specific challenges that they encounter when treating patients with OUD, as well as common clinical scenarios where they might encounter patients with OUD, and then kind of from their own societies, what are the formal guidelines or accepted best practice treatment paradigms, harm reduction strategies, and also kind of their recommended role of what the in-hospital psychiatrist is supposed to do in these cases. And so these, this discussion really generated some critical insights that we then used to develop the framework for the work of our work group. So several threads emerged from the roundtable discussion. First, and something we've already mentioned, is that psychiatry is really under-recognized as the owner of substance use disorder treatment. In fact, most specialties identify addiction medicine and even pain medicine as the primary specialists for SUD treatment. The American College of Surgeons noted that psychiatry is rarely considered to assist with these patients out of sheer lack of the knowledge that psychiatrists actually treat addiction. And so this insight, really suggested that the specialty of psychiatry may have an inaccurate and perhaps one-sided impression of, ownership of substance use disorder treatment in the general hospital, and that this requires examination. Second was that the stigma associated with substance use disorders really continues to be a barrier across all parts of the healthcare system, and certainly is impacting systems level decisions about policy as well as allocation of resources. So within psychiatry then, close attention is really needed to look at our roles as, our own collective contributors to stigma, with consideration of why psychiatry has not proudly owned this field, nor has it required the education necessary for psychiatrists to be current in treating and educating others about OUD. Finally, or thirdly, I should say, there's really a widespread education gap across specialties that begins in medical school and is reinforced in postgraduate training, really through absence of well-defined ACGME competencies for treating patients with substance use disorder. And then finally, and perhaps most importantly, our roundtable discussion really highlighted the fact that there are abundant opportunities for high impact collaboration across specialties to educate and advocate for this high risk population. So for today, the goals of our workshop are to apply best practice protocols for induction, maintenance, and microdosing of buprenorphine, to list common barriers to the treatment of OUD, to describe some of the specialty-specific considerations when treating patients with OUD in the general hospital, to talk about innovations for transitions of care, including bridge clinics and patient navigators, and then finally to apply strategies for reducing the culture of stigma surrounding OUD in the general hospital. So with that, I will turn it over to Dr. Allison Smith, who will discuss initiation, maintenance, and other key pearls about using MOUD in the general hospital.
Well, thank you. Well, I'm Allison Smith, and I'm going to talk a little bit about initiating MOUD in the hospital. So I have no disclosures. And some of my objectives for my section are going to be talking about initiating the treatment for opiate use disorder in the hospital setting and the benefits of it, discuss some of the federal regulations which allow persons with opiate use disorder and opiate withdrawal to be treated with buprenorphine or methadone in the hospital setting, as well as discussing microdosing as kind of a novel approach for buprenorphine inductions. So I'm going to start out here with a case. This is actually a patient that I've took care of. Mr. H he's a 32-year-old male with a history of opioid use disorder using IV heroin, history of hepatitis C, endocarditis with a tricuspid valve replacement 3 months prior to this admission, who presents to the hospital with left foot pain and discoloration, admitted to the ICU with sepsis. He underwent a left BKA for ischemia secondary to his septic emboli about 2 weeks prior to consultation. He was also noted to have an echocardiogram with a large vegetation on the tricuspid valve, which confirmed recurrent endocarditis. The inpatient psychiatry consult liaison team was consulted for difficulty with weaning IV opioid pain medications post-op in the setting of his history of addiction. So in terms of a history of opioid use, like many patients, he was first exposed medically. He was exposed to opioids after a back and knee surgery in high school from playing football. He developed a tolerance to the prescribed pain meds and began buying them illicitly on the street when the prescriptions ran out. Shortly after, he started buying heroin because it was stronger and cheaper. At his peak, he was using about 1 to 2 grams of heroin IV daily. So he was hospitalized 2 months prior at an outside hospital and had a tricuspid valve replacement. He remained there, completed the 6 weeks of IV antibiotics. He was able to abstain from all substances during that time. However, he was not started on any maintenance treatment for opiate use disorder. Shortly after his discharge, he went home and he lived with his fiance and child, and he relapsed. He and his fiance had been using daily together. He had lost his job, his house, custody of his child. He also shared that he had several legal charges related to his drug use. Prior to this current hospitalization, his use had not escalated as much, and he was using less than he was prior to the first hospitalization. He was using about 0.25 to 0.5 grams of heroin IV daily. His last use of heroin was 3 days prior to admission, which now this is about 2 weeks out when we're consulted. The urine drug screen at the outside hospital did confirm he was positive for opiates. He had prior outpatient treatment with Suboxone and methadone for about 4 to 5 years ago. He stopped the medication with the Suboxone due to cost, and then he had issues with transportation, so methadone wasn't an option anymore. He felt the medications were helpful for his cravings, and he is interested in re-engaging with treatment for his opioid use disorder. We already talked about his past medical history. He had no prior psychiatric history, hospitalizations, suicide attempts. Substance history was also significant in that he was using methamphetamine IV, but he reported it being more than a year ago. He also had a pretty extensive use of alcohol use, but had quit 10 years ago and currently smoking 3 to 4 cigarettes a day. No allergies. Medications were just significant for multimodal pain management by the primary team, as well as IV Dilaudid PRN and oxycodone PRN. He's homeless, unemployed. He was working in landscaping before this. He has a 5-year-old and 8-year-old daughter, a fiance who also uses, as previously mentioned, and a family history with a brother with opioid use disorder, also using IV heroin. So we'll get back to that case a little bit further on. So in terms of substance use disorders, we know that they are chronic medical illnesses that have evidence-based treatment and, more importantly, life-saving treatment for them. These substance use disorders result from neurobiological changes that cause dependence and craving. Patients with opioid use disorder that are hospitalized for medical or surgical reasons are a particularly high-risk group of people. Hospitalization is an opportunity to initiate these evidence-based medical treatment. Studies show that the treatment of hospitalized patients with injection drug use associated infective endocarditis is largely focused on management of the infection, starting them on IV antibiotics, multiple procedures, and that interventions that are actually addressing the primary underlying condition, addiction, are lacking. Inpatient initiation of MOUD and maintenance on discharge improves completion of recommended medical treatments, such as the IV antibiotics for the infection, improves the transition from inpatient to outpatient for substance use treatment specifically. It decreases the risk of recurrent infections and decreases readmission. There's a randomized controlled trial done by Lipschutz et al. That demonstrated that hospitalized patients who were started on buprenorphine treatment were significantly more likely to engage in outpatient treatment for their OUD. The study showed that the linkage group that were started on buprenorphine maintenance in the hospital had a percentage of about more than 70% entering treatment, while the detox group, where buprenorphine was stopped after 5 days, had less than 12% entering treatment. We also know that these patients were 40% less likely to report using illicit drugs 6 months post-discharge compared with patients that were randomized to detox. So while medical and surgical patients generally do not come to the hospital seeking addiction treatment, among those with opioid use disorder, 2/3 are interested in wanting to stop using opioids, and about 50% are interested in MOUD. The patient motivation for treatment is high in the inpatient setting because they're frequently hospitalized for complications from their use, and the immediate removal of the substance it causes them to have withdrawal symptoms, which are obviously very uncomfortable. So despite all this evidence about the efficacy of MOUD and the benefits of initiating it in hospitalized patients, many patients that are hospitalized do not receive optimal treatment for their OUD or for their withdrawal symptoms. There was a study done in 2016 in an academic tertiary care center with patients with injection drug use associated infective endocarditis that showed that less than 8% of patients were discharged with any plan to start MAT. So, and there's another study done that in patients who developed endocarditis as a result of injection drug use, that connecting them to addiction treatment after discharge was associated with a 70% reduction in mortality. Yet again, only 20% left the hospital with a referral. This same study found that 1/3 of patients died during a median follow-up period of 3.6 years, and the average age of death was 36 years old. So without offering and initiating effective treatment, there is a risk of disrupting evidence-based care in the inpatient setting. We lose the opportunity to offer corrective treatment for endocarditis to treat the primary chronic medical illness of addiction. We increase the risk for AMA discharges and for both in-hospital and outpatient illicit substance use. And most importantly, patients have a higher mortality. So When a patient is admitted, like we talked about, to the inpatient unit for care, inpatient providers have this opportunity to provide medications for opioid withdrawal, potentially start maintenance, and connect individuals with outpatient treatment. However, there's often an area of confusion that exists regarding the legality of both initiating and or continuating medications for opioid use disorder, methadone and buprenorphine maintenance. So methadone maintenance and initiation of methadone treatment by federal law must take place in a federally licensed opioid treatment program. However, there are exceptions to these federal regulations that exist for continuation of previously initiated methadone outside of the federally licensed treatment program, as well as for buprenorphine in unwaivered providers. So in the outpatient setting and historically, buprenorphine can be prescribed, both initiated and maintained by any approved provider. And by approved provider, that refers to the Data 2000 waiver or the notice of intent. However, patients that are admitted for a primary medical or psychiatric issue other than a diagnosis of opioid use disorder or opioid withdrawal, such as endocarditis or any other medical condition, may be administered buprenorphine or methadone to prevent opioid withdrawal and to avoid complicating their acute medical issues. This is by the Title 21 law, the Title 21 Code of Federal Regulations, which I'll go into a little bit more detail. But for methadone, the prescriber may initiate it for the purpose of opioid detoxification while patient is admitted to the hospital. Again, for a medical or surgical reason other than opioid use disorder. It should be noted, though, prescription of methadone cannot be given on discharge. A patient must follow up in an opioid treatment program. I will say this does not apply for methadone for analgesia. Anyone that, for pain, any provider could prescribe methadone for pain. Buprenorphine can also be initiated by any inpatient provider with a DEA to avoid opioid withdrawal. Again, noted if unwaivered or without a notice of intent, a provider cannot write a prescription for buprenorphine at discharge. So this could create a lot of issues at discharge for follow-up. So in terms of continuing methadone or buprenorphine for a medical hospitalization, Title 21 Code of Federal Regulations allows for prescribers who are not authorized or waivered to continue previously initiated methadone maintenance or buprenorphine in these medically hospitalized patients. This regulation was originally written when methadone was the only available agent for treating opioid use disorder, but it now does apply to buprenorphine or buprenorphine naloxone as well. So a physician who or other authorized or any other authorized hospital provider may maintain, or as I previously mentioned before, detoxify a person with buprenorphine or methadone as an incidental adjunct to medical or surgical conditions other than opiate use disorder. So when continuing methadone or buprenorphine for hospitalized patients, the most important first step is to coordinate with the patient's outpatient provider or with the outpatient opioid treatment program. For methadone, usually you could just call the opioid treatment program that the patient is attending, and you want to confirm their dosing, but also you want to confirm when their last dosing was. If it's that they've missed more than 3 or more consecutive doses, you may want to consider a dose reduction. You also want to take into account the patient's current clinical medical situation and stability, as multiple medical conditions can affect sedation, as well as a lot of different medications that we prescribe in the hospital may interact with methadone. For patients that are taking buprenorphine at home or prior to the hospital, again, you want to confirm the home dose. And you can do this by calling the patient's pharmacy or checking the prescription drug monitoring website. And again, if the provider is unwaivered and doesn't have their notice of intent, you cannot write for this prescription at discharge. So you'd want to confirm that they had a supply. If the home dose of, going back to methadone, if the home dose of methadone cannot be immediately verified, sometimes a low dose of like 10 to 30 milligrams can typically be safe. So this is the Title 21 in much more detail. So per the 130607 administration or dispensing of narcotic drugs, nothing in this section shall prohibit a physician who is not specifically registered in a narcotic or opioid treatment program from administering opioid treatment medications for the purpose of relieving acute withdrawal symptoms, while making necessary arrangements for outpatient follow-up. So this applies to the emergency setting as well as a hospitalized setting. In the emergency setting, like emergency room, this only applies for 72 hours. So you can only give one dose of medication for withdrawal per day, and it cannot exceed over 72 hours. So you can only do it for 3 days. When patients are admitted in the inpatient setting, you can continue the treatment while they're hospitalized. So talking a little bit about the buprenorphine initiation. So for those patients with OUD that are interested and eligible, the acute hospital setting provides a prime opportunity for engagement, treatment initiation, and then connecting them with outpatient care. This inpatient setting allows for a high level of monitoring. It also allows for non-medication support by staff members to the patient, access to adjunctive medications that can help with symptom management of opioid withdrawal, which can increase or improve the chances for a successful induction. The inpatient setting can also be particularly helpful for patients who are really medically complicated, have a high risk for complicated withdrawal, such as those that are using high dose opioids, multiple substances, and those exposed to fentanyl, which can make traditional inductions more difficult. So the big concepts are: one, wait for the patient to be in withdrawal. And typically the consensus is around a CAL score of 8 or more. Then you want to initiate buprenorphine. There's multiple different protocols that exist, anywhere from giving the first dose of buprenorphine sublingually 2 to 8 milligrams. Most of the ones that I see are typically 4 in the inpatient setting. You can do 2 if you're really concerned about over sedating, or they're complicated, or you're really worried about precipitating withdrawal. You could also do higher. So I've seen some protocols that will give the first dose at 8, especially for patients that have severe opioid use disorder and using IV. They may tolerate a higher dose. And you have the luxury of being in the inpatient setting where you can have really close monitoring. So after giving the first dose, you want to evaluate in 1 to 2 hours, repeat a CAL score, and then you can redose with an additional 4 milligrams if there's no signs of precipitated withdrawal and they're tolerating the medication okay. Then you can, most protocols suggest you can repeat the doses every 2 to 4 hours, every 4 to 6 hours, until the patient is no longer craving or experiencing withdrawal symptoms. Most protocols suggest that the maximum dose is 16 milligrams on day 1. And then you want to titrate and reassess the patient daily to get rid of the cravings and withdrawal. Maintenance dose usually is around 16 to 24 milligrams. Some may tolerate less, and I've seen as high as 32 milligrams, but that can be a little bit harder sometimes, at least in my experience, to get approved by insurance and whatnot. So talking a little bit about maintenance, once you have started patients on either methadone or buprenorphine and intend to continue prescribing as maintenance, again, methadone typically is only through a federally licensed opioid treatment programs. But again, like we talked about, it can be given to patients hospitalized for a condition other than opioid use disorder or opioid withdrawal. Pros of this: you'll get the patient more comfortable. You'll quickly help eliminate withdrawal symptoms and cravings. They'll have a lower risk of relapse when patients discharge. Cons are that, especially with methadone, it requires a lot of coordination during the admission with the local opioid treatment program. Most of these are only open very early hours. You got to make sure that they're taking patients, they can get there for an intake, they can get their dose the next day, because again, you cannot discharge a patient with any methadone for when it's prescribed for addiction. This can be really challenging for patients that are admitted in the inpatient setting that require more care, such as going to skilled nursing facilities for further antibiotic treatment or physical therapy. Once they sort of leave the hospital, you sort of lose that tabs on them, and it's difficult to, at least in my experience from an inpatient setting, to successfully arrange that follow-up. Buprenorphine, again, is usually outpatient, data waivered, or an exempt provider, but we can start maintenance treatment by a provider with a DA in the hospital. And pros of that, again, similar to methadone, increase patient comfort, decrease the risk of AMA discharges. One study compared buprenorphine to clonidine and showed 5 to 7 times less risk of leaving AMA with using buprenorphine. There's a decreased risk of relapse. And when you compare, when compared to tapering medications, there's improved engagement and with outpatient treatment. There's a decreased cravings, and it does not require daily dosing outside the hospital like methadone would. Cons, again, you'll need to find a community provider to continue maintenance on discharge, and you can also still run into similar issues if a patient is going to a skilled nursing facility coordinating that care. So also want to just briefly talk about buprenorphine microdosing. So microdosing is a novel approach to buprenorphine induction that entails starting very small doses of buprenorphine while still giving full mu agonist opioids. And I will say there are no randomized controlled trials that show or that have been done with microdosing yet, but there are several case reports, case series that show that microdosing is very well tolerated. There's also some now that suggest it may be helpful in patients with illicit opioid use, including fentanyl in the outpatient setting. But in general, the microdosing method eliminates that need for abstinence from opioids prior to starting buprenorphine. Like we talked about earlier, you've got to wait 12 to 24 hours from the last dose of just a short-acting opioid and wait for patients to be in moderate to severe withdrawal. And for a lot of patients, they are terrified of withdrawal, and it's very hard for them to abstain. And especially when they're in the medical hospital setting or have had a recent procedure, precipitating withdrawal is really tough, and most patients are really not wanting to go through with a traditional induction. So this method sort of adds tiny doses while still giving the opioids. You can use a patch, or you can just use sublingual buprenorphine, which I'll show you that here on the next slide. But you can continue the full agonist opioids during this period of induction, around 5 days of starting the low dose of buprenorphine. Some protocols suggest weaning the full agonist opioids over the 5 days. Some suggest you can still just continue the dose that they're at. It doesn't seem, from my review, to make much difference whether you're weaning them or not. I suppose at really high MMEs, it could make one. So most of the studies try to get them as close to 90 as possible. But again, this method can really expedite buprenorphine induction, particularly for post-op patients that are hospitalized for OUD, or post valve replacements, sternotomies, like the gentleman in our case who's had a BKA. And in general, this seems to be very well tolerated by patients with minimal withdrawal symptoms or cravings. So briefly, here's the two approaches. One is using a transdermal buprenorphine or butrans patch, ranging from 5 to 20 micrograms per hour. This usually will give about 0.3 milligrams or less, probably with absorption of a total daily dose of buprenorphine with the 20 microgram patch. So you put on the patch, you wait 48 hours after placement, and then after 48 hours, you can start sublingual buprenorphine 3 times a day. Then you gradually sort of increase the sublingual buprenorphine with a goal of around 2 to 4, 3 times a day by day 5. On day 5, you can stop the patch, the butrans patch, and you can discontinue the full agonist opioids. The other method does not use the butrans patch and just immediately starts low dose sublingual buprenorphine. Typically, this can be lower. I've seen anywhere from 0.125 to 0.5, and it's known as the Bernice method. It can be a little challenging because the films, the buprenorphine only comes in the 2 milligram films that I've seen. So very hard to cut those, especially to 0.125. Big challenges with the butrans patch is only FDA approved for pain, is not approved for addiction. So it's using it off label. They're very expensive. So even if you are using it for pain, it typically requires prior auth. Really challenging to get, in my experience, in the outpatient setting. Luckily, in the inpatient setting, we do have it available. So I've been able to have access to that in the inpatient setting. So this is just a quick figure kind of describing both methods on the same slide here. It's from one of the PCS webinars. Matt Perez, a physician, family med physician out in Washington. I really liked how he presented this and this slide here. So here you can see the old opioids. So this is the full agonist. On the bottom here, this is the method using the buprenorphine patch. So you start the patch day 1. After 48 hours on day 3, you start the sublingual bup 1 TID and gradually increase to a target of 2 to 4, 3 times a day by day 5. Day 5, you remove the patch at bedtime and just continue and remove the patch and stop the full agonist opioids. And then from then on out, just continue on the sublingual bup here. The other method starts low dose buprenorphine sublingually on day 1 without the patch. So here they do 0.5. You can do 0.5, you could do less but again, more challenging with cutting the films and gradually increase. The patch, based on the number of MMEs, correlates to what patch you want to use. If patients are on more than 90 MMEs, most of the studies or case reports suggest using the 20 microgram patch. So again, back to our case. So on interview with Mr. H with the C-L team, he endorsed 10 out of 10 pain at the site of his VKA. He was also complaining of phantom leg pain. The primary team did have him on an aggressive multimodal pain regimen. And again, they had been weaning him back on his Dilaudid. He was currently on 1.5 Q4 when we saw him, and PO Oxy 10 to 15 Q6. Primary team was very concerned. They were having difficulty weaning. He wasn't tolerated and were getting frustrated. Patient was very upset with the team that they were trying to taper the Dilaudid too quickly, as he felt it was the only thing giving him any relief. And he also was already experiencing withdrawal symptoms. He was also frustrated about the communication between him and the hospitalists, and felt he had a lot of kind of mistrust about the medical staff in general. He did express interest in Suboxone to the CL team and felt that it had been previously helpful with his pain and for his cravings. However, throwing a little wrench in it, the team was notified that the primary team was planning to transfer patient back to an outside hospital as soon as there was a bed. So they very much pressed that they wanted to get him out of the hospital as soon as possible, which when we saw him, the patient was receiving more than 90 MMEs of full agonist opioids. So this presented a challenge. So we really wanted to get him on buprenorphine prior to discharge and avoid the mistake of him not being discharged on treatment like his prior hospitalization. So he was really reluctant to proceed with a traditional induction. He was terrified to go on withdrawal. He was already in pain, but we were able to talk with him about some potential other options. So what would you recommend for Mr. H with opioid use disorder on these high doses, more than 90 MMEs, complaining of pain at the surgical site and withdrawal symptoms with already having withdrawal symptoms? So treatment options we discussed. You could discontinue all the opioids same day and offer him clonidine and other meds for symptomatic treatment of withdrawal. Don't think that is the most compassionate one. You could taper the full agonist opioids over 5 to 7 days and then stop, discharge on no opioids or MOUD treatment. You can taper the agonist, you can taper the medications, wait till he's in withdrawal, 12 to 24 hours, and then start buprenorphine for maintenance and withdrawal. Again, this is the traditional approach, but he was very reluctant to stop and wait until he's in withdrawal to start buprenorphine. So you could also discontinue the opioids and start either methadone or for withdrawal or maintenance. Though again, that presents its own challenges. And I will say that every hospital has their own policies, and state to state regulations can vary per the Title 21 federal law. So it's important to make sure you familiarize yourself with that. Another option we talked about was continuing his opioids and start a buprenorphine patch with plans to introduce the low dose buprenorphine after 48 hours. And this we were really getting him to buy into, that he wouldn't have to go into withdrawal. We also could have done it without the patch. So we decided to continue his opioids, get him to buy in that we were gradually going to go down on the opioids and start the buprenorphine. Though he's a little reluctant because he said it went against anything he'd ever heard about buprenorphine and opioids, he agreed. So this is basically exactly what we did. So this is we were not consulted until about day 16 when they were trying to go down. As you can see, he was requiring as much as 164 MMEs for opioid pain management. Well, the day we saw him, the team had basically discontinued his IV Dilaudid, but we ended up again, I don't think we had to wean the oral oxy, but we just kind of almost psychologically held his hand through it and weaned him down. And by day 3, we started him after 48 hours of being on the patch. We started him on the 1 BID, 2 BID, 4 TID. And by the last day, he was on 4, 4, and 8. His pain, fortunately, responded really well to the buprenorphine. He rated his withdrawal a 2 compared to usual 10. He could not believe that he was not in more withdrawal. And fortunately, he was a pain responder to bupe as well. So he went to a SNF, he completed his IV antibiotics. He unfortunately had 2 subsequent admissions for recurrent bacteremia and septic emboli, because every time they stopped the IV antibiotics, he had a recurrence of bacteremia. However, he remained on bupe this whole time, and his UDS was negative. Eventually, he was readmitted with cardiogenic shock and bilateral pulmonary emboli. And the team, this cardiothoracic surgeons, agreed to do a redo valve. So 10 months later, he's still on buprenorphine 12 daily without any relapses. He spends his time with his 10-year-old son and living with his mother. He's going to college classes, majoring in criminal justice. He just got a job working at a golf course. He got his prosthetic leg and is taking care of the greens. And I just heard last week, he's actually a patient I follow outpatient now. I sort of bridged him to myself. The court dropped his felony charges because they were related to drugs with all of these other good things he has going on. So he also has plans and aspirations to become a peer recovery specialist one day. So this is just one example of how impactful starting MOUD in the inpatient setting can be. And then a cool way that you can use the buprenorphine microdosing approach if patient is post-procedure.
My name is Sean Jin, and I'll be talking about the barriers to treatments for OUD. I have no disclosures. So some of the objectives are to identify the common barriers that patients may face when obtaining care for OUD, and to see what can be done to address these barriers. So we'll start with the case. Miss M, she is a 17-year-old G1P0 at 28 weeks gestation, African-American, homeless, emancipated adolescent with history of opioid use disorder, who was found unconscious on the sidewalk outside of a convenience store in a rural township of Idaho on June 21st, 2020. Bystanders report that the patient was observed injecting something with a needle into her arm prior to passing out. When paramedics arrived, Narcan was emitted ×2, and she was able to regain consciousness. She is now in the local ER for workup and observation prior to discharge. Looking at this case, what barriers can be identified from the initial presenting information? So first up, the gender, and then there's the age, certainly the race. Geographical location also presents an important aspect, her housing status, and lastly, COVID-19 is, that was when COVID-19 was still very much not under control. So looking at the gender barrier, it's been shown that women are 1.7% less likely to obtain care after an overdose when compared to men. And nationally, pregnant women are less likely to receive medications for opioid use disorder when compared to non-pregnant women. From the picture from Vanderbilt University, we also can see that pregnant women typically experience greater wait times, and less providers are willing to prescribe MOUD to pregnant patients. Second is the age. Here we can see that adolescents and transitional age youths are significantly less likely to obtain treatments when compared to adults. Next, we look at race and immigration status. In these bar graphs, we can see that Black Americans are the least likely to obtain care and treatment follow-up after an overdose from opioids, regardless of the type of opioid used. Next is Hispanic Americans. And we see that white Americans are the most likely to obtain treatment and follow-up after an opioid overdose. And this also brings up the population of undocumented patients who have substance use disorders. They are less likely to come to the hospital for follow-up for fear of any legal troubles or fear of deportation, whether or not those fears are real or not. So the case continues. After the patient was stabilized and OBGYN consultant cleared the patient and the fetus, prior to discharge was also seen by psychiatry, and the patient was offered resources for substance use treatment. And follow-up was also made for the patient at her PCP office. A month later, the patient missed the PCP appointment, unfortunately, and continued to use substances. And she was not able to go to the appointments for her substance use treatment because they were too far away and there was no public transportation. And the ones that were closer to her didn't offer the treatment methods that she was hoping to start. And this brings up the next big issue, which is socioeconomic status. In a review in 2017 of all of the available private and public plans in 2017, 14% of Medicare and Medicaid plans do not cover any form of MOUD. Of the remaining 86% of the plans that do cover for MOUD, 43% of those plans that do cover Suboxone require prior authorization, which serves as another barrier and another extra step for patients who want to obtain care. And then even less plans cover long-acting forms of MOUD, which in many studies have already shown to be more effective in helping to prevent relapses. And in a population of veterans who struggle with substance use, it's found that those with housing assistance and case management are 4.5 times more likely to engage with MOUD programs. Although this cannot be extrapolated to the general population, I think it does give us a picture of an alternate way of practicing medicine and providing healthcare when there's a single payer system and more resources can be dedicated to help treat patients with opioid use disorder. Next, we see here a geographical map of the United States. And this is a map comparing the whether or not each county in the United States has at least one buprenorphine provider or prescriber. And then comparing that with what happens in 2016. And what the blue means is that there's consistent buprenorphine providers in those counties between those 4 years. And what we see in the white is that there's no buprenorphine providers at all, either in 2012 or 2016. And then the blue, and then the yellow is there was none in the 2012, but then a prescriber became available in 2016. And then the red is when a prescriber is no longer available that was available in 2012. And so when we look back to the case, we can see in Idaho, there are about, in 2012, there's 13 counties that have the blue, that have prescribers. And we see that, over the next 4 years, 3 counties lost their prescribers, but 7 new counties gained prescribers for a net gain of 4 additional counties with prescribers in that state. And additionally, because of the rural aspects, the rural nature, there's also a paucity for public transportation to get patients to and from their appointments. And in many studies, including one in Vermont, there also appears to be, because of the long travel time, the travel time significantly impair the ability of patients to hold jobs, which adds another layer of complexity and barrier. Additionally, despite of having substance use disorder treatment facilities, actually 2/3 of them don't offer any form of MOUD. And of the 1/3 that do offer them, only 6% offer all 3 FDA approved forms of MOUD treatments. And additionally, there just lacks significant funding and support staff that help create the clinics and the treatment centers. And additionally, currently, there's only 7% of the prescribers in the DEA registry that can have a 275 patient panel to prescribe buprenorphine. And there also lacks a standardized curriculum within the medical school, within residency training programs on OUD and MOUD. And when a review was done on different studies and curriculums published in the analysis found that only 9% of those studies led to positive impact on patient care, despite over 91% of those studies had a positive impact on the medical education, though without significant change to practice outcomes. And lastly, we did talk about COVID-19, and that we see here in the case that there was a significant spike in overdose deaths in June 2020, around the height of the pandemic. And that is thought to be because there's less bystanders to apply the Narcan in those situations of overdoses, and there's just decreased access to care because at that period of time, I think a lot of the country was still struggling with how to deliver telehealth appropriately. And so what can we do? Certainly licensing bodies and medical boards can help require standardized training programs for medical students, healthcare providers on screening, diagnoses, and treatments for OUD. And then the other very big aspect is advocating with Congress for both increased opportunities for trainees to go into addiction medicine or psychiatry, and to also increase the incentive and reimbursements for those who are in those specific areas. Lastly, it would be great if insurance are required to provide coverage for all 3 FDA-approved medications for OUD treatment, and also in expanding coverage of the Medicaid. And next, I'll hand it over to Dr. Funk.
In this section of the workshop, I'll be touching on some high points about specific specialties, primarily infectious disease and the treatment of the pregnant patient. So let's start with a case. So you are a C-L psychiatrist and you're consulted to see a 36-year-old man with opioid use disorder who's been injecting heroin for the past 10 years. He's now in the ICU with recurrent endocarditis of his prosthetic tricuspid valve, which had actually been replaced 3 years ago, also due to infective endocarditis. He has never been on medication treatment for his opioid use disorder, as he was taught once in a prior treatment program that MOUD, like buprenorphine or methadone, is just a crutch that replaces one opioid with another. The CT surgery team is consulting you because they would like your opinion on the futility of replacing his valve again. And they would like you to initiate a treatment contract stating that he can only get another valve if he abstains from heroin. So this is a common scenario that might be encountered and is a great segue into our brief discussion about infection. So let's jump right in. So we know that many specialties, including hospitalists, internists, ID, cardiology, numerous surgical specialties, all encounter patients with OUD who are presenting with bloodborne infections that are transmitted via injection drug use. And these can include infectious endocarditis, cellulitis, osteomyelitis, septic arthritis, epidural abscess, HIV, hepatitis B, and hepatitis C, amongst others. A recent review of public health data examining IV drug use related infection syndromes estimated that a prevalence of at least 100,000 cases of skin and soft tissue infections, as well as an incidence of thousands of episodes of infective endocarditis occur annually in the United States. The rise in IV drug use associated infection related hospitalizations has resulted in a significant increase in hospitalization costs, even when accounting for inflation. So one study looked at data from 2002 to 2012, which demonstrated that the total inpatient charges for OUD related infections increased from approximately $190 million to $700 million, with an estimated charge per hospitalization of approximately $100,000. So infective endocarditis, which we've heard a little bit about already, is a very commonly encountered infection. It is a common complication of IV drug use, and it accounts for an increasing percentage of the mortality and healthcare costs that's associated with opioid use disorder. The mechanisms by which IV drug use can increase the risk of infective endocarditis include direct injury from particulate matter, from use of contaminated equipment and non-sterile injection techniques, as well as direct cardiac physiologic effects, including vasospasm and cardiac injury. 16% of infective endocarditis in North America is due to IV drug use. And the incidence of injection drug use related infective endocarditis in people who inject drugs is 1.5 to 4 cases per 1,000 years of IV drug use. Surgical intervention, which is usually involving a valve repair or replacement, is required in about 20 to 40% of IV drug use associated endocarditis patients at the time of their first episode. And then more than half of these patients will actually go on to require repeat surgical intervention due to ongoing drug use. The optimal management of IV drug use associated endocarditis really requires collaboration with cardiology, cardiac surgery, and the psychiatry and addiction teams. And there really needs to be a dual focus on both the infection and the substance use disorder. Now, interestingly, the American College of Cardiology and American Heart Association guidelines for the management of patients with valvular heart disease recommend that in patients with IV drug use associated endocarditis, that consultation with addiction medicine occurs to, quote, discuss the long-term prognosis for patients refraining from actions that may risk infection before they will consider repeat surgical intervention. And it's notable that these guidelines don't comment at all on the provision of SUD treatment for patients with infective endocarditis. And perhaps this is due to similar reasons why psychiatry has not more actively owned this, including lack of training and knowledge, perhaps misperceptions about the feasibility of initiating MOUD in the hospital, and perhaps due to lack of outpatient MOUD prescribing resources. Certainly, we think stigma continues to play a role. Now, it's important to note that policies requiring abstinence as a requirement for surgery, including the use of signed contracts, are ineffective, especially when, during this critical period of acute endocarditis, when management of the substance withdrawal may not be prioritized, and that patient is not feeling well during that time. Furthermore, the expectation that a written agreement will somehow compel abstinence really fails to consider the neurobiology of substance use disorders. It fails to consider comorbid psychiatric illness, as well as the complex psychosocial conditions that a patient is encountering. And it certainly not so subtly promulgates really disparate medical treatment for patients diagnosed with a substance use disorder. Furthermore, the position that surgical treatment of endocarditis in people who inject drugs is futile or wastes resources is quite incomplete, when we know in most cases the underlying opioid use disorder has not been treated according to recommended standards of care. A retrospective cohort study of 768 subjects with OUD who were hospitalized with infective endocarditis found that patients who had received MOUD, and this was primarily naloxone and buprenorphine, within 30 days of discharge had a lower opioid-related overdose rate and a lower one-year rehospitalization rate than patients who had not received MOUD. So this is very important that we're considering this when working with these patients. So we know that sharing of equipment by people who inject drugs increases the risk of infection with both HIV and hepatitis C. From 2007 to 2017, thinking about infective endocarditis, though the overall incidence of infective endocarditis remained stable, it increased significantly in young people. So if you look at the figure on the right, this shows the rates of reported HCV infection by age. And you can see a really dramatic increase in use and infection in persons aged 20 to 39. The figure on the left shows the reported risk behaviors among people with reported HCV infection. And you can see that injection drug use is at the top. IV drug use is now the most common risk factor for acquiring HCV. And interestingly, looking at HIV, in earlier years of the HIV epidemic, it was primarily acquired through sexual behaviors rather than in people who inject drugs. Now, from 2007 to 2017, the incidence of infective endocarditis decreased in persons living with HIV. But notably, there have been several recent outbreaks of HIV in people who inject drugs, again, specifically in young, white, rural populations without any access to syringe services programs or MOUD. And we saw this occur with the HIV outbreak in Indiana. The provision of MOUD with opioid agonists to persons living with HIV has a quite significant positive impact on receipt and adherence with antiretroviral treatment, HIV viral suppression, HIV transmission, and use of illicit opioids. And finally, a meta-analysis of the association between opioid agonist therapy and HIV incidence demonstrated a 54% reduction of new HIV infections with use of MOUD. Now, infections in people who inject drugs can be prevented through implementation of harm reduction strategies and MOUD. Harm reduction interventions include syringe services programs that provide many things, including access to clean injection equipment, including sterile syringes, needles, water, filters, cookers, fentanyl test strips, alcohol swabs, products for hand hygiene, and bleach for cleaning syringes. These SSPs can also be a really convenient setting for clinical engagement and other harm reduction services like initiation of MOUD, HIV pre-exposure prophylaxis or PrEP, education about infection prevention, and even treatment of minor infections. The little figure on the right is the front page of the Harm Reduction Coalition's safety manual for injection drug users called Getting Off Right. And this can be found at harmreduction.org. This is a comprehensive and high yield resource for both people who inject drugs and for the clinicians who are treating them. And it's a how-to guide that provides instructions for people who inject drug on safe practices for choosing materials, and here you can see a diagram of safest injecting locations with first, second, and third choice. They show injection techniques, what are correct versus incorrect. The guide also talks about management of health complications and overdose, and is really quite comprehensive. The Harm Reduction Coalition website also includes really useful resources with links to directories for SSPs, naloxone distribution, and local buprenorphine providers through SAMHSA. So now let's shift gears a little bit to pregnant patients. This is a highly specialized population that really faces some unique challenges and even greater stigma. And the stigma against pregnant patients is really operationalized with punitive practices under the guise of protecting the fetus from opioid exposure. Many states have statutes that consider illicit substance use during pregnancy to be reportable as child abuse or neglect, and a few states cite OUD during pregnancy as grounds for civil commitment. Unfortunately, the fear of legal consequences has not been a motivator for pregnant women to cease use of illicit drugs. Rather, it's a barrier that may drive women from seeking or continuing care, leading to increased risk of adverse outcomes for the mother-infant dyad. Counseling about the use of illegal substances while pregnant, as well as legal and social consequences with consideration to county, state, and local laws is really essential. And healthcare providers really need to know the laws in their region regarding custody of newborns or other children of mothers with untreated opioid use disorder. The Guttmacher Institute compiles data on the current state policies about substance use during pregnancy. And this is just a snippet from the top part of a very extensive table comparing all of the states. Notably, there are 23 states, including the District of Columbia, that consider substance use during pregnancy to be child abuse under the civil child welfare statutes. 3 consider it grounds for civil commitment. 25 states and the District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 states require them to test for prenatal drug exposure if they suspect drug use. On the positive side, 19 states have either created or funded drug treatment programs specifically targeted to those who are pregnant. And 17 states and the District of Columbia provide pregnant people with priority access to state-funded drug treatment programs. So many of these punitive practices really play out within this construct of the deserving versus undeserving mother. And we know that pregnant women with OUD really face overwhelming shame that is often reinforced by the healthcare system itself, as well as healthcare providers who don't want to offer them care. And this can result in reduced pre- and postnatal care, or with mothers who only receive care at the time of delivery. In 2018, SAMHSA published with the American College of Obstetricians and Gynecologists this really fantastic set of clinical guidelines for healthcare providers who treat pregnant women with OUD. It's available online, and it is just an outstanding comprehensive resource all about prenatal care, infant care, maternal postnatal care, approach to MOUD in the pregnant patient all throughout pregnancy. I strongly encourage everyone to read this guideline. It is extremely useful and can inform quite a bit of your practice. So thinking about the approach to MOUD in the pregnant patient, we know that medically supervised withdrawal is not recommended during pregnancy, as it's associated with a high rate of return to substance use, which puts both the pregnant woman and the fetus at risk. Pregnant women should be offered treatment with methadone or buprenorphine, which can reduce the risk of injecting drugs, which can then reduce the risk of infection. These medications can also reduce cravings and withdrawal, and this can allow the pregnant woman to really direct focus on prenatal care as well as stabilizing her environment in preparation for the new infant. There is no known risk of birth defects with methadone or buprenorphine. And historically, pregnant women being treated with the combined buprenorphine naloxone were transitioned to the single agent buprenorphine without naloxone in order to protect the fetus from exposure to naloxone and to avoid precipitated withdrawal if the combination drug were to be injected. We know that this kind of situation is a myth anyway in terms of psychopharmacology, but there is a lot of evidence now that pregnant women being treated with combination bup and naloxone may not require a transition to buprenorphine alone and do not experience significantly different outcomes. There are no standardized guidelines for initial dosing of buprenorphine or methadone in pregnancy, nor for dosing adjustments as the pregnancy progresses. Really each patient requires an individualized assessment. We know that for methadone, as dosing can take days to even weeks to find a stable dose, high-risk pregnancies may require hospitalization for methadone initiation to prevent illicit drug use due to untreated withdrawal or cravings during that kind of prolonged dose titration. Methadone clearance rate increases during pregnancy, and so this typically necessitates a higher dose, especially in the third trimester. Dividing the daily dose can help to stabilize the methadone level. And then with buprenorphine, similarly, you may need to increase the dosing during the third trimester due to increased clearance. There's insufficient data to support the safety of injectable naltrexone in pregnancy. Women already taking injectable naltrexone should be offered methadone or buprenorphine if they choose to discontinue the naltrexone. And notably, as naltrexone levels fall, there will be increased agonist activity due to the loss of opioid tolerance. The pregnant woman's daily dose of buprenorphine or methadone should not be expected to provide analgesia during the peripartum period, nor should buprenorphine or methadone doses be increased to control peripartum pain. We know that patients with OUD are at high risk for insufficient pain relief from the standard therapies that women may usually be offered. And we know that they may require higher doses of non-steroidal analgesics, acetaminophen, or short-acting opioids. The use of epidural, spinal, and or short-acting opioids, including morphine sulfate, fentanyl, and hydromorphone, are appropriate analgesic options during labor and delivery. Finally, thinking about pregnant women with OUD and the risk of neonatal opioid withdrawal syndrome, we really need to provide education to pregnant women about the risk of this syndrome. We know that NOWS, as it's now called, it used to be called neonatal abstinence syndrome. It can be less severe in neonates of patients treated with buprenorphine versus methadone. There's no evidence to suggest that lower doses of bup or methadone will impact the risk, intensity, or duration of neonatal opioid withdrawal syndrome. And breastfeeding is recommended for women who are stable on buprenorphine, on the combined buprenorphine naloxone, and on methadone. And in fact, buprenorphine and methadone drug levels are very low in expressed breast milk. Mothers do need to know when they should or should not breastfeed. And so, although a stable mother being treated for OUD with pharmacotherapy is encouraged to breastfeed her infant, there are a few situations where it is not recommended. And this includes a mother who is HIV positive, has tuberculosis, is Hep C positive, or who has returned to illicit drug use, including cannabis. So with that, I will now turn things over to Dr. Suzuki.
So my name is Joji Suzuki. I'm an addiction psychiatrist at Brigham and Women's Hospital, and I'm going to cover transitions of care. And so no financial disclosures that are relevant on my part. Here's my case. Mr. B is a 45-year-old male with a history of major depression, PTSD, and opioid use disorder who is admitted for a painful abscess in his forearm where he injects frequently. The abscess is drained and pain is well controlled, and he's amenable to starting sublingual buprenorphine. And we've heard a lot already about the importance of medications for OUD in the hospital. And he admits he's been using it on and off in the streets, but he's amenable to getting formal treatment. And so he's referred to a program by the hospital social worker, and the addiction consult service is able to facilitate the initiation of this medication, and also write the prescription for until his follow-up appointment. So this is all great. So everything we've heard so far by these terrific speakers is really the importance of providing, adequate addiction treatment while these patients are hospitalized. We've heard a little bit about pain control, et cetera. But one of the things that happens in our healthcare system is that there's a real disconnect between what happens in the hospital and what happens afterwards. And so if we don't provide adequate sort of linkage following the hospitalization, we sort of miss this opportunity to make sure there's continuity of care. But that's a real challenge. Inpatient teams are inpatient teams, which is separate from the outpatient world. And so the siloing of the inpatient outpatient world is part of the problem. And so we can't necessarily solve that. But I want to talk about some of the strategies that we can employ to try to improve that connection. And this patient in particular, is going to have a lot of challenges after he leaves the hospital. So, but first, of course, when we do start medications for OUD in the hospital, does that actually benefit post-hospital outcomes? Absolutely. We do know that overall it does improve linkage to care following discharge. It reduces discharge AMAs quite a bit. Some hospitals have baseline rates of discharge AMA as high as 50% for this patient population. So just by simply utilizing medications for OUD, both buprenorphine and methadone, we can reduce it dramatically. We also know that it can reduce readmissions. And also, as Dr. Funk really did a nice job of talking about the infectious complications of injection drug use, simply using medications can improve IV antibiotic completion rates. And so these are all, well and good. This is the good news. The bad news is that when you look at across the different studies, looking at the successful linkage, meaning the person actually shows up at their aftercare appointment for, let's say, buprenorphine. And then most of the studies are looking at buprenorphine. And these are studies mostly from Boston area. MGH, we did our own study, Boston Medical Center, and also Portland, Oregon. What these studies generally show is that as soon as patients leave the hospital, about 50% never make it to their follow-up appointment. When you extend this out to 6 months, most of the studies show that by the 6-month point, maybe 10-20% of patients are still in treatment. So this suggests that linkage rates are really poor despite our efforts in starting medication treatment in the hospital. And then once you look at 6 months out, the majority of patients are not in treatment at all. Now this is the line would represent sort of the typical outpatient treatment. So by definition, somebody who comes to outpatient treatment are linked, 100% at start. But on a typical outpatient program for buprenorphine or methadone, 6 months retention rate hovers around 50%. So if half of your patients are still in treatment at 6 months, we consider that actually pretty decent. And so what this suggests is that one of the critical things we need to focus on is that we need to improve the linkage rates after leaving the hospital, because once we do that, the trajectory of this, the slope of this line looks pretty similar. Meaning that if we can really bump up the linkage rates, probably we might actually approach what we see in the outpatient setting. Now, one of the clues here was the study from Yale. What they did was they did a randomized trial of patients who show up in the emergency room with opioid disorder and randomized them to either getting essentially referral to treatment from the ED or starting buprenorphine, writing a prescription, and referring those patients to a local program. And in their study, what they didn't really highlight as much, but it was probably one of the most critical interventions, part of this intervention, was that the destination clinic was their own clinic at Yale, and they guaranteed an intake within 72 hours of referral from the emergency room. And if the clinic was open, they actually would walk over the patient to the clinic like a warm handoff. Now, the clinic, which was a primary care clinic, was not a specialty addiction program, guaranteed an intake within 72 hours and would treat the patients for up to, I believe, 2 months. At that point, they would be referred out to some continuity clinic somewhere else. But this allowed for a dramatically improved linkage rate approaching 80%, meaning 80% of the patients who were referred to the clinic showed up. So dramatically better than what we would see from a typical hospital to outpatient linkage rate. Now, so that's the bad news. Another bad news is that, again, when you look out further, outcomes are pretty poor for this patient population. So there's much better data, longer term data on those suffering from serious infections like endocarditis. And this is a study that we did, looking at all the patients in a given 3-year period who were admitted for endocarditis from injection drug use and offered medications for OUD. The majority accepted either buprenorphine or methadone. Some declined. And that actually showed us that initiation of medication for OUD was feasible for this patient population. But then what we did was we looked at their longer term outcomes. And what we discovered was that it didn't have any impact. Medication treatment didn't have any impact on mortality or repeated episodes of endocarditis. Now, of course, this is a small study, but it was kind of alarming that even those who accepted buprenorphine and methadone had repeat episodes of endocarditis within 1 to 2 years. In fact, 30 to 40% had another episode of endocarditis within that time period, which is very, very alarming. Now, this was then confirmed by a much larger study that was published last year. They used what's called a Chapter 55 data set, which actually looks at every single individual in Massachusetts and can link hospital data, pharmacy data, EMS data, death index, outpatient treatment, all sort of connected at the individual level. It's actually quite a remarkable sort of data set. And what they did was looked at every single individual in Massachusetts who had a hospitalization for endocarditis from 2011 to 2015, and looked at whether they were started on medication treatment after, at the time of the hospitalization or within 3 months of that, and whether that had any impact on overdose and mortality overall. What they discovered is that during the months that the individual was on MOUD, that actually had an impact on reducing overdose mortality, which is what we know already. But what was alarming here was that whether the individual was started on MOUD or not, at 1 year, the overall mortality was no different, suggesting that retention of treatment was poor, or that these individuals continued to persist in injection behavior, which resulted in additional infectious complications, which drove mortality. It's probably a combination. And this is in Massachusetts. As you saw from Dr. Jin's talk, if you notice that the access to MOUD treatment, the Northeast is completely blue, suggesting that we actually do a pretty decent job of keeping access to treatment available. So even in places where access is relatively good, patient outcomes are really poor. Again, suggesting that this is a patient population that really suffers from poor outcomes, both in the hospital and once you leave. And so initiating medication treatment alone may not be enough for this patient population, which is sort of the bad news. Let's continue the case. So Mr. B never made it to the intake appointment as planned. He did continue to take sublingual buprenorphine for a few days, but resumed illicit opioid use before his intake. So he says, "Look, I really tried, doc. I just couldn't wait 2 weeks." And this is a common scenario. In fact, 2 weeks is an eternity for a lot of these patients. Once you leave the hospital, you're feeling better. It's really hard to maintain that motivation, and you're back in your sort of day-to-day environment, which is very triggering, and it's hard to maintain your sobriety all the time when you're trying to manage your medical symptoms, etc. So actually, there's a lot of research to try to look at just overall, how do you improve transitions of care from the hospital to the community? And this is, all comers, all kinds of hospitalizations. And so several themes really emerge. And there are many, many interventions that do help, but these are some of the key areas. Intervention that helps to monitor and manage symptoms of the medical hospitalization, whether that's pain, infection, etc. And educating and promoting self-management, really empowering patients to be able to sort of, monitor and manage their, appointments, et cetera. And then finally, enlisting social and community supports. Now, this is a tall order for a lot of our patients, especially if you're suffering from addiction. And so there's some specific interventions that have been tried, but there actually aren't that many. The first is actually this idea of really reducing wait times, just like we saw in the Yale study. If possible, same-day appointment. If not, really reducing that time. And actually, this study from Boston Medical Center did show that if you shorten the wait time between discharge and appointment, they simply ask the question, if the appointment is on the same day or the day after versus 2 days or longer, does that make an impact? And the answer is absolutely. You have 2.5 times greater odds of successful linkage if the appointment is within a day. Once you hit 2 days, already the outcomes are worse. And then so as you can imagine, if you extend out to 1 week, 2 weeks, 1 month, forget it. The goal will be, if possible, same-day access, same-day linkage. Now, this is, again, hard to do. So what the Yale study did was actually not only advocate the initiation of buprenorphine in the emergency room, but to advocate this idea of a bridge clinic. And it really caught like wildfire. And many institutions across the country have now launched their own versions of bridge clinics. And the basic idea is to take patients coming out of the emergency room or the hospital and provide as timely linkage to treatment as possible, provision of medication treatment on demand, buprenorphine, and other addiction medications, addressing basic medical and psychiatric comorbidities, and then holding them for a period of time until we can transition them to something longer term, just like they did it at Yale. And so this idea of a bridge clinic, low barrier, low threshold, all comers coming, and even without even an appointment, just walk-in model. And this is the intervention that's really seems to really improve linkage rates. And so another really sort of benefit of having a bridge clinic is that just the busy slide is simply to show that there are many ways that patients can enter our system. And Dr. Funk mentioned this at the very beginning about sort of different entry points. Unfortunately, even in large systems where there's adequate specialty care, addiction consult service, primary care-based addiction treatment, oftentimes they're very siloed, and coordination among them is actually very difficult. And so having a low barrier, low threshold model like a bridge clinic can really facilitate the coordination across the entire system. That's what we've seen in our system as well. Another intervention, in addition to sort of bridge clinic, low barrier, is patient navigation. And so at University of Maryland, they've been actually doing this study for quite some time, and they actually have an addiction consult service in the hospital. But in addition, what they did was a randomized trial to add a social worker who provide proactive case management, advocacy, helping with transportation, linkage support, doing motivational interviewing, and then not just during the hospitalization, but continue for 3 months in the community. And they had the randomized trial, 200 individuals to receive the NAVSTAR, they call it the NAVSTAR Intervention Navigation Services, versus treatment as usual, which is, as we all know, it's sort of like at the time of discharge, here's your prescription, here's your appointment, good luck. And what they're able to show is that this simple navigation services by a social worker dramatically reduced readmissions, but also improved linkage within the time frame they compared. So they looked at 3, 6, and 12 months, and at every time point, it basically there was greater linkage to overall addiction treatment, but also medications for OUD linkage. So just adding a social worker to really enhance that, both in hospital and up to 3 months, can really make a difference. Another thing that actually have been growing interest is peer support. When you think about addiction treatment, we think about 3 legs: medications, if they're available, counseling of some type to teach about relapse prevention, et cetera, for example, and then peer support, creating a recovery-oriented environment, social and physical environment. And so peer support comes in many varieties. It can be a form, sort of like a AA setting, or getting a sponsor, or just having peers in your group therapy. Those are peers as well. But what's really gaining popularity is actually having certified peer recovery coaches. They come in a variety of names, but recovery coach is probably a more common one. And then again, peers have been utilizing addiction treatment for many decades in the US, but these formal peer support programs, evidence is now emerging, and it's somewhat mixed. Peer support alone probably has a mild to moderate impact on substance use outcomes as an adjunct to existing therapies. And so one of the things that we were interested in to see, can actually recovery coach enhances transitions of care, just like they did for the navigation services or addiction consult service. If you add this on top, does it have any impact? So we did a randomized trial. We're actually completing it now. Manualized recovery coach intervention compared to treatment as usual, and looking at treatment retention at 6 months. And this intervention is very, very structured. There's workbooks, there's pre-specified, frequency of encounter, etc. And patients work on a sort of a workbook, create a real prevention plan, etc. Unfortunately for us, and so we had 26 patients overall, 14 and 12 in each arm. Overall retention actually was better in the recovery coach arm at every time point. But the difference is really not big enough to be significant, and also show that actually we had a very high linkage rate for both groups. And the part of the challenge here was that as we were launching the study, our own bridge clinic opened up. So that probably diluted the impact to some degree because everybody had great linkage. As I mentioned earlier, the baseline rate is about 50%. And so by bumping up the linkage rates for everybody, we probably kind of doomed our study. But still, there's a signal that recovery coach intervention might be helpful. And specifically looking at time to discontinuation of treatment, there's actually a longer delay, even though ultimately at 6 months there's no difference. The recovery coach intervention may delay the time to discontinuation. It may keep patients longer in treatment, and so more research is really needed to see the real impact of that. And so basically, what we see is that a little bit better than our historical controls, but not as good as outpatient treatment or what we saw at Yale. Okay. Case continues. Mr. B comes back to the hospital 6 months later, admitted for a spinal abscess. His infection is stabilized and the antibiotic regimen clarified. He's instructed to stay in the hospital for 6 weeks until completion of the treatment. Buprenorphine is reinitiated with good effect. He feels he's being treated differently by the nurses and complains of the restrictive hospital policies that limit his freedom of movement and privacy. He asked the medical team if there's any way he can be discharged home to complete the antibiotics. Doc, not sure I can handle being stuck here for another 2 weeks. I think I'm going to lose my mind. And so, as we all know, hospitalizations are already difficult for patients. They're medically sick. It's difficult to manage. You may be in pain. If you add on top of that substance use disorder, that makes it even more challenging. Now make this into not a 3-day hospitalization or 5 days, but 6 weeks. All these problems are compounded. The stigma that these patients experience, the restrictive policies, all of these really get magnified. And patients, especially with those with history of trauma, may find these sort of being cooped up. Loss of privacy, loss of freedom of movement can be extremely distressing. And so one of the things that we asked was, is it ever possible to discharge these patients home with a PICC line? And of course, the conventional wisdom has always been that no, because these individuals will invariably inject through their PICC lines, therefore they should not be discharged. And so we actually did a literature review to sort of find out, is there any data to support that? And at the time we did this, we found 10 published studies across the world showing that actually people have tried this. And overall, OPAT completion rate. So OPAT stands for outpatient parenteral antimicrobial therapy, meaning sending the patients home with a PICC line to complete IV antibiotics at home. By the way, OPAT is a standard of care for serious infections for those who don't inject drugs. That's the standard of care for most places. This is routinely done across the world, but routinely people who inject drugs are excluded from OPAT. But what we found is that OPAT completion rates for those who have tried this actually similar to people who don't inject drugs. Mortality similar, complications generally similar. The only thing that seemed to be a little higher was actually readmission rates tended to be higher. But across the board, the vast majority of studies showed that PICC line tampering, PICC line misuse complications were either non-existent or relatively rare. Some of the studies did show high rates. One from Pittsburgh had a very high rate, but overall, a pretty low rate. So this actually led us to sort of argue for a pilot. This is a challenging population to begin with. This is challenging, distressing hospitalization. If there's any way to send them home, let's try to figure it out. And so we implemented a program. We would actually get the support from the hospital to provide OPAT for those who qualify. And this is a multidisciplinary approach where we had to agree to these terms, that all the teams, the primary team, the medical, the surgical teams had to be on board. The infectious disease team and the addiction team had to also be on board. Everybody had the veto power in a way. The person could not be homeless, had to be willing to come to the bridge clinic for ongoing monitoring, had to be willing to be on medications for OUD, at least for the duration of the antibiotics, and agree not to tamper with the PICC line. And majority of patients who were offered this, who met criteria, accepted the offer. Actually, some patients who actually declined, they didn't feel like they could trust themselves to actually be safe. So those patients actually stayed in the hospital. But for those who agreed, they were very grateful. About a third of the patients with serious infections in a given year in our first year pilot actually met criteria and agreed. So there were 20 individuals, mostly endocarditis. So these are serious infections, 100% IV completion rate, zero PICC line complications. We did exit interviews with every individual as when the PICC lines were removed. Sort of, hey, by the way, in retrospect, was a PICC line like tempting? Did you actually, tamper with it? Across the board, I know how to inject. I'm an expert at it. I don't need to use PICC line. I would never try to jeopardize it. I'm very grateful. Now, some individuals did relapse. Now, but they actually were honest about it, told us about it, and they got readmitted and completed their antibiotics in the hospital. But again, this demonstrated that the OPAD is feasible even among those who inject drugs. And we saved 500 inpatient days in that single year. So patients are happy, the hospital staff are happy, and the hospital leaders were happy as well. So in conclusion, transitions from the hospital to the outpatient is a very fragile time for our patients, for every hospitalized patient, but particularly for OUD patients. And MOUD initiation is critically important, but it may not be enough. One of the important interventions might be a bridge clinic, but including navigation services or peer support may be helpful. And then finally, OPAD actually may be feasible for those who inject drugs as well. And that concludes my part, and I'll pass it on to Dr. Buonocore.
Hello, my name is Stefania Buonocore, and I'll be presenting on stigma and culture of change through the liaison day-to-day work. I have no disclosures to report and no conflict of interest. Next slide. Okay, so just an overview of what I'll be going through today, some culture change through day-to-day liaison work. I'll start with the case example and then go through some of the impact of stigma and specifically mental health stigma, and then go through some strategies for reducing this culture of stigma, especially surrounding opioid use disorder in the general hospital, and how we might ease teams through this stigma. Next slide. So to start off with the case, Mr. R is a 30-year-old male with past psych history of PTSD, opioid use disorder, history of IV use, and past medical history of MSSA endocarditis the year prior, who presents to the ED after being turned away for a planned admission at a substance rehab facility. He reports that he had failed to present within the correct window of time for this planned admission, and he cites transportation issues as the main problem for getting there within that window. And so he requests help from the medical staff with connecting to another rehab facility and also receiving his daily dose of methadone for the day. On arrival, his vital signs were stable, his urine screen was positive for fentanyl and methadone, and additional lab work was notable for elevated transaminases with ALT of 330, AST of 180. His mental status exam was unremarkable overall. He was quite calm and engaged, on the quiet side, but no signs or symptoms of acute intoxication or withdrawal symptoms. Next slide. He described some negative feelings associated with prior presentation to the rehab facility just that morning. He said he felt judged, didn't belong, was really just felt unwelcome, undeserving of a spot at the place. This was just compounded by him being denied the entry. He goes on to report recent stressors, including a breakup with his girlfriend and a verbal disagreement with his brother. As a result of these arguments, he no longer has a place to live. So further feeling judged, a sense of failure, and letting his family down. He also reports last use of fentanyl was 3 days prior when mentioning the urine tests in the ED. He cites some goals of wanting to stop using opioids, however, has some difficulty with describing his motivations. He also makes a comment about being on methadone and how he's not happy being on a replacement for fentanyl. And so he requests alternative options for residential treatment programming. Next slide. So to pause from the case, just looking at stigma and its definitions, it can be thought as an attribute, behavior, or condition that is socially discrediting, typically a set of negative beliefs that a group or society holds about a topic or a group of people. Stigma is rarely based on facts, but rather on assumptions, preconceptions, and generalizations. This can result in prejudice, avoidance, rejection, and discrimination. It can occur in the medical setting, and this can be known as diagnostic overshadowing, which is the process of over-attributing patient's symptoms to a particular condition. For example, if they have known depression and come in with a physical complaint, the provider may automatically attribute the complaint to depression. Next slide. Certain conditions are more stigmatized than others, and this is thought to be the product of what might be perceived as the fault of an individual, or if the individual might have perceived control over the situation or the condition. So when talking about substance use disorders, if there's a high perceived fault and that the individual might have control over the use disorder, this would put it in a highly stigmatized condition. Next slide. And these are the three main categories of stigma. So there's intrapersonal, which is the self-stigma, and that's what becomes internalized in the individual. Interpersonal is between non-stigmatized groups, and they can harbor these negative beliefs about the stigmatized groups. And then structural or institutional stigma, which can really encompass societal values, cultural norms, organizational policies. And this can ultimately change where power and resource allocation might end up when you're talking about a community or a hospital. And this can also reflect beliefs that people with addiction may be less treatable or less deserving of care. Next slide. To continue a little bit with the case, the social worker replied that most facilities in the vicinity that had current availability would not take a patient on methadone. Furthermore, the ED attending denied ordering a dose of methadone, saying the patient abused before arrival, given the positive urine test. The patient grows increasingly anxious and restless. Ultimately decided he was too uncomfortable, could not wait for further medical workup or meeting with the social worker again. He requests to leave the hospital with plans to go to a friend's home. Next slide. So here's an example of why intrapersonal or the self-stigma is particularly harmful, is the culmination of this perceived social stigma that is then internalized. The person may confuse feeling bad with being bad, recurrent negative self-thoughts, in turn having reduced self-esteem, disempowerment, and ultimately at its worst, detachment from treatment or disengagement. Next slide. How might we start easing teams through stigma? So to start, some education in addiction biology. During the natural progression of substance use disorder, a loss of control over goal-directed behaviors and an ability to adapt to reward stimuli. And we know this is the biological underpinning of the progress of the disorder. Having understanding of this may reduce some beliefs that opioid use is solely under the individual's control. Also identifying some mental health champions to develop partnerships with the treatment team, serve as a patient advocate and educator, further bridging gaps. Also highlighting success stories, perhaps in place of M&M conferences. This might mitigate perceived inability to help patients with OUD. Increased exposure to individuals with lived experiences of prior substance use may also promote that bridging of the gap between two populations that might have the stigma. Next slide. This is an important topic that's becoming more widely spread, and it's specifically about the language that we use and why language might matter when talking with patients or talking with staff or coworkers. There's one study that they surveyed just over 1,000 community members, and they portrayed options, giving a definition of what a safe consumption site would be, and giving the same definition, but calling it an overdose prevention site. Just by changing those two terms, they showed that the groups that was surveyed, they significantly supported the overdose prevention site as a preferred term, and that they would actually support legalizing this in their community. Another study showed that it does matter how we refer to individuals with substance use disorder. And this study surveyed mental health specialists that were presented with the same synopsis. However, one term was changed. One synopsis, the person was called an abuser, and in the other, it was called person with substance use. Participants felt that the substance abuser had many more negative outcomes. So they felt that they were less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, and more able to control their substance use without help. Next slide. So further going on language, to have person-first language means several things. It shows that a person has a problem rather than is a problem. It avoids eliciting negative associations, punitive attitudes, and individual blame. Prevents a person from believing they are only perceived as the group. For example, a person with substance use disorder versus an addict, a person in recovery versus a former addict, or just simply use versus abuse. Using these terms can restore empowerment, and it also removes an implication that a person is choosing to use substances or can choose to stop. This can remove negative judgment and punishment. Next slide. Some more examples of terms that would be recommended to avoid versus use. So opioid replacement therapy, which was one of the terms that the patient in the case had used. And it is a misconception that medications replace or substitute one drug or addiction for another. So instead, it's recommended to say medication treatment for OUD or opioid agonist therapy, or even just simply pharmacotherapy. When referring to urine tests, avoiding terms such as clean and dirty, and instead replacing them with testing negative, not in active use, testing positive. These are more clinically accurate and in alignment with descriptions of other medical conditions. By making these changes, you can improve a patient's sense of hope and self-efficacy of change. Next slide. So understanding the impact of patient-centered discharges, there are significantly worse outcomes and increased risk of mortality with readmission of patients previously discharged and with the term against medical advice. Some strategies would be identifying risk factors to help reduce future occurrences. And over the years, there's been many features that highlight where these occurrences might be happening more. And these have been identified, such as younger age, male sex, lack of insurance, history of substance use, mental illness, lack of a primary care physician, living alone, or prior hospitalizations. Furthermore, undertreated pain or withdrawal symptoms or social obligations at home, which could be in the case of the patient that we were speaking about. However, it was never really found out what his true reasons were for leaving. I think, as Dr. Suzuki also mentioned, methadone use while in the hospital was a protective factor. And just understanding these patient-centered discharges, we're finding more and more that they may be more related to a combination of factors that are present on admission and hospitalization, rather than the breakdown in the therapeutic alliance between a physician and a patient. Next slide. And also, as I think it was mentioned earlier, just acknowledging some of these punitive policies and perhaps their carceral associations. Institutional policies have a tendency to view substance use disorder as a social justice issue rather than a chronic medical condition. And this can reflect a lot of structural stigma. And, some of aspects of care perceived as punitive could include mandating urine tests, having a safety sitter or security presence with the patient while they're admitted, having to change into hospital garb, maybe with supervision, having wellness checks for contraband, holding their home medications, methadone or buprenorphine, until the dose is confirmed by their outside provider. Next slide. And just as Dr. Suzuki was mentioning, the co-occurring history of trauma or even PTSD and how this might impact a patient in the hospital. And the co-occurring PTSD is highly prevalent in patients with OUD. And it's difficult to predict what environmental factors may cause an increased trauma response. And therefore, this idea or this application of universally based trauma-informed care is recommended to encompass all scenarios that you might have. There's some key elements identified in the practice of trauma-informed care, and that these include that trauma influences interpersonal relationships, experiences of treatment, having a recognition or acknowledgement of trauma histories and screening for that on admission. Also respect for privacy, as well as physical and emotional safety, and ultimately avoidance of triggers from past trauma. Next slide. And to go a little bit further, some examples or instances where there might be a higher risk of having this trauma response. They can occur, during a physical exam or a pelvic exam, preparing for an endoscopy or an imaging exam, waiting in a small room, maintaining a vulnerable position for a prolonged period, even just having the back towards the examiner. Any of these could cause a trigger in someone that might have had a traumatic experience in their life. So some strategies to overcome these or mitigate these could include, knocking before your entrance, making it very clear you're, announcing yourself before seeing the patient, before they see you. Also thoroughly explaining the steps of an upcoming procedure or physical exam. And this might be even more detailed, such as the expected duration of the exam, the location of physical touch on the patient, and how long that might last. Next slide. And finally, to highlight just how complex a lot of these interactions are, and the importance of having a team approach and having this shared decision making, and how the role of the C-L psychiatrist might fit in. And so having this decision making as a whole, as a collaborative event, and that's augmented when it's shared between multiple members of the treatment team and the patient. Often the patient who is admitted is quite medically ill. And as we're seeing, a lot of medical complexity is growing over the last few years. And so even just having that connection with the patient to promote that education and bridge those gaps can be really rewarding and valuable. So the psychiatrist on the team can also serve as an educator, bringing the knowledge and basis of neurobiology of addiction and trauma disorders, how the patient subsequently relates to the world and relates to their care. This brings the utility of being able to recognize psychological factors that precede the AMA or patient-centered discharge. Also, there's the benefit of motivational interviewing as a skill and as a primary non-judgmental tool to help understand how patients make decisions to self-discharge. Further help manage co-occurring mental health conditions, and ultimately optimizing patient care and transitions of care. And that's the end of my part of the presentation. So I'll turn it over to Dr. Fung for the final wrap up.
So I want to thank all of our wonderful speakers for today, and thank you in the audience for your attention to hear about this really important topic. I do want to encourage all of you, if you have any questions at all for any of the speakers today, please do feel free to reach out to us. We'd be happy to answer anything and have more discussion about this topic. Have a wonderful meeting and good to speak with you.